Hypertension is having high blood pressure, so the pressure in the blood vessels becomes raised. The purpose of treating hypertension is to reduce the risk of heart failure, stroke, coronary events, and renal impairment. There is different stages of hypertension, which can be classified into stage 1, 2, and severe hypertension. In stage 1, the blood pressure is greater than or equal to 140 over 90 millimeters of mercury. In stage 2, the blood pressure is greater than or equal to 160 over 110 millimeters of mercury. And in severe hypertension, the systolic is greater than 180 or the diastolic is greater than 110. So in stage 1 hypertension, you treat the patient who is less than 80 years old only if their kidney or heart are affected or if they're diabetic, or if the patient has a 10-year cardiovascular risk which is greater than 20%. Stage 2, all the patients are treated, and severe hypertension is a medical emergency. Before treating hypertension with medication, changes in lifestyle can be done to help reduce the strain on the heart and reduce the blood pressure. These lifestyle changes include stop smoking, reducing weight, reducing alcohol and caffeine intake, and reducing salt and saturated fat intake. The drug treatment for hypertension depends on the age of the patient. So if the patient is below the age of 55, first-line medication include either an ACE inhibitor or an angiotensin receptor blocker. If either of these drugs are contraindicated or not tolerated by the patient, a beta blocker can be given instead. Second line involves the addition of a calcium channel blocker. However, if a calcium channel blocker is not tolerated or the patient cannot have it due to the risk of heart failure, for example, a thiazide-related diuretic can be used instead, for example, chlorthalidone or indapamide. If the blood pressure remains high despite this, third line means adding a thiazide-related diuretic to the ACE inhibitor or angiotensin receptor blocker and calcium channel blocker. Fourth line involves the addition of a low-dose spironolactone or increasing the dose of the thiazide diuretic that was added in step 3. If the patient is older than 55 or of Afro-Caribbean descent, the treatment differs slightly. First-line medication is a calcium channel blocker, and if this is not tolerated or there is a risk of heart failure, a thiazide-related diuretic can be given instead. Second line involves the addition of an ACE inhibitor or angiotensin receptor antagonist. Step 3 and 4 are the same as they would be when treating an under 55-year-old patient. If at any stage a thiazide diuretic is contraindicated, an alpha or beta blocker can be given instead. Despite this treatment, if there is a great risk of cardiovascular disease, a statin or aspirin can be added in order to reduce the risk of an event. This drug treatment for hypertension is a stepwise approach, and each step is normally tried for 4 weeks before moving to the next step. Blood pressure targets differ depending on the age or medical condition the patient has. If the patient is below the age of 80, the blood pressure target is below 140 over 90 millimeters of mercury. If over the age of 80, the blood pressure target is below 150 over 90 millimeters of mercury. If the patient has kidney disease, the aim is to keep the blood pressure below 140 over 90 millimeters of mercury. However, if the patient has chronic kidney disease, the blood pressure should be below 130 over 80 millimeters of mercury. A diabetic blood pressure target is below 140 over 80 millimeters of mercury, and if the diabetes is causing complications of the eyes or kidney, the target is below 130 over 80 millimeters of mercury. If the patient is pregnant and has chronic hypertension, the blood pressure target is below 150 over 100 millimeters of mercury. The treatment for hypertension differs slightly for different conditions. If the patient is pregnant, for example, methyl dopa is normally the first choice. Labetalol is the second choice, and if these agents have failed, nifedipine can also be used. ACE inhibitors and angiotensin receptor blockers should be avoided as they decrease fetus blood pressure and inhibit their growth. In patients with renal disease, hypertension is normally treated with an ACE inhibitor. This is because it slows down the process of renal impairment by inhibiting the renin-angiotensin aldosterone system. Or a high-dose loop diuretic can also be used in renal disease, but a thiazide diuretic will not work. Severe hypertension is normally managed by reducing the blood pressure gradually over 24 to 48 hours with either labetalol or a calcium channel blocker like amlodipine or felodipine. There is other antihypertensive drugs that can be classified into three groups. Firstly, vasodilators, which have a potent hypotensive effect, meaning they reduce blood pressure very powerfully, especially when used with a beta blocker or a thiazide diuretic. Vasodilators will increase cardiac output and cause tachycardia, so it is important to give them with a beta blocker. Vasodilators can also cause retention of fluid, causing the fluid to build up, and because of this, should be given with a diuretic. Examples include hydralazine, which is used for resistant hypertension, but very rarely, minoxidil for severe hypertension, and sildenafil for pulmonary hypertension. Pulmonary hypertension is increased blood pressure in the arteries of the lungs. The second group is called centrally acting hypertensive drugs. These drugs work on the central nervous system and cause it to reduce the sympathetic tone. So they work by preventing the speeding up of the heart rate. Examples include a methyl dopa, which is used in pregnancy as mentioned before, clonidine, which can cause side effects like flushing. Another problem with clonidine is that if it stops suddenly, it can cause rebound hypertension and so increase blood pressure even more. And the last drug in this class is Moxinidine. The third group is alpha receptor blocking drugs, which work by blocking the alpha receptors, causing the blood vessels to dilate. An issue with alpha blockers is that they can reduce blood pressure very rapidly after the first dose and should be taken at bedtime to avoid standing. Examples include doxazocin, prazosin, and terazosin.